Pulmonary empyema, or basically pus inside the pleural cavity. Pleural empyema is the collection of pus in the pleural space. The fluid is thick, opaque, it's exudative, and it's very foul-smelling. The word pus just makes it sound right. It's just thick and nasty, and I don't know how to explain it. It just stinks. It smells very bad. It's very thick. You can't see through it. It's really a bad smell. The plan of care is to empty the empyema out of the pleural cavity. Sometimes they'll do a thoracentesis, but a lot of times it's too thick, so they actually will go to the OR. Because a thoracentesis that they do in radiology, they can only put in something as large as a chest tube, which we've seen the diameter of those, and a lot of times they needed a bigger space to get that that pus drainage out. And then after they do that, they'll have a chest tube to help with re-expansion of the lungs. And then they'll be on antibiotics to control the infection. Most common causes of empyema are pulmonary infection, lung abscess, or an infected pleural effusion. But the care of those are sometimes with thoracentesis, but usually it's too thick and they have to go to the OR. Once the majority has been removed, they'll do re-expansion with chest tubes, and then the patient will have antibiotic therapy. And then they'll of course will send the pus down for culture and sensitivity to find out which antibiotics will assist with clearing up that infection quicker. They'll start with a more broad span antibiotics, and then as they get the sensitivities back, we'll put the patients on an antibiotic that is for that specific antigen. And that's all you need to know about pulmonary empyema. Know that it's a collection of pus in that pleural space and how it's cared for. And the most common causes are the pulmonary infection, lung abscess, and infected pleural effusion. The last thing we're going to talk about for care of the patients with infectious respiratory problems is tuberculosis. So tuberculosis is defined as TB. It is highly communicable. It's slow growing. The transmission risk decreases when an infected person receives proper drug therapy for 2 to 3 weeks. TB is one of the most common bacterial infections worldwide. In fact, 1/3 of the entire adult population of the world has latent TB. TB is transmitted via aerolization, or it's an airborne route. And what that means is when a person with active TB has airborne particles of the TB from the respiratory system, either by laughing, coughing, sneezing, whistling, singing, anything that's getting those respiratory droplets out into the air, and then another person inhales it. Not all that inhale it, though, will develop active TB. And that is because of our normal immunity. So when the person who inhaled the bacillus from the TB, the bacillus begins to multiply freely when it reaches a susceptible site, whether it be the bronchi or the alveoli. At this point, we will have the development of acquired immunity to TB, and further growth of the bacilli is controlled in most cases. The lesions usually resolve and leave little or no residue of the bacilli. Only a small percentage of adults infected with the bacillus ever develop active TB. Cell-mediated immunity against TB develops 2 to 10 weeks after infection and is manifested by a positive reaction to a tuberculin test. The primary infection may be so small that it does not appear on a chest x-ray. So now let's look at the person who is infected and does develop active TB. The initial infection is seen more often in the middle or lower lobes of the lung. The local lymph nodes are infected and enlarged. There's usually an asymptomatic period that follows the primary infection, and this can last for years or decades before clinical symptoms develop. This is called the latent period, and an infected person is not contagious to others until symptoms of the disease occur. Now, this initial infection would be seen on a chest x-ray, even if it was in the latent period, because of the infected lymph nodes and spots on the lungs. Secondary TB is a reactivation of the disease in a previously infected person. It is more likely when defenses are lowered and immunity is reduced. This is seen a lot in elderly patients, patients with chronic disease, especially those with HIV. Okay, so if you look at this picture here, it's also on page 606 in your book. You see the transmission of the TB organism, okay? And then you see the little TB lesion. And if you look at 90 to 95% of infected individuals have a primary lesion that's walled off by the, and it forms a scar that will be shown on the chest x-ray. Now, these people will be positive on a PPD. 5 to 10% of the infected individuals progress to active TB. And what that means is that the cavities open up into the bronchi and allows the spread of the tuberculosis through coughing. Okay, so 90 to 95% of infected individuals, the primary lesions wall off so that they can't spread the infection. But 5 to 10% of the infected individuals will progress to active TB. Health promotion. What are some things that are risk factors for developing tuberculosis? Constant contact with untreated persons, being immunocompromised, homeless, communal living, and drug abusers. So when you look for the patient with tuberculosis, you want to look at, do they have a recent travel history? Have they had an exposure? A lot of times they'll complain of progressive fatigue, chills, nausea, anorexia, unintended weight loss, irregular menses, low-grade fever, and especially night sweats. Their lungs will have crackles. They sometimes will have a cough, and they will have hemoptysis or blood streaks into their sputum. And I can promise you, if TB comes up on an NCLEX exam, it's going to talk about the low-grade fever, the night sweats, and the hemoptysis, and the blood streaks in the sputum causing the hemoptysis. Those are the telltale signs of TB, being that low-grade fever, the night sweats, the coughing with the blood streak sputum. A purified protein derivative, or the PPD skin test. A positive reaction does not mean that the person has active disease, but it does indicate exposure or dormant disease. If a person has a positive PPD, a chest x-ray is done to detect whether it is an active disease or if it's healed lesions. And a lot of times, especially with healthcare workers, they'll have a positive PPD, and then when the chest x-ray, it doesn't show anything at all. There's not even signs of an active or a healed lesion. On the other hand, if the patient does have um, active nodules noted in their chest x-ray, a sputum culture is used to confirm the diagnosis of TB. So what precautions are taken when the patient is inpatient? They're placed in a negative pressure room. You use both standard and airborne precautions. Their room needs to be a private room. N95 respirators need to be used by all hospital personnel. And the patient needs to make sure they're wearing a surgical mask in the hallway. TB, patient education and home care. Strict drug regimens for 6 months. Direct observation therapy leads to more treatment success and less relapses. That means that the patient takes the drug regimen in front of a healthcare worker. At home, airborne precautions are not necessary because family members have already been exposed. All household members need to be tested for TB. Sometimes they're just treated if they're very close or if they're immunocompromised. The patient needs to make sure they wear a mask outside of the home and puts any tissues that they've coughed into a plastic bag. They will have sputum cultures every 2 to 4 weeks. 3 consecutive sputum cultures are negative, then they are no longer infectious. Nursing interventions for TB. Airway. You want to make sure they have an effective cough and are able to expectorate their secretions, they have plenty of fluids, and that they turn, cough, and deep breathe. They need to make sure that they're following their medication regimen. And remember, a medication regimen that is observed by a healthcare professional is more likely to be adhered to. Remember that it's usually a combination therapy. Rifampin makes oral contraceptives non-effective. That a strict adherence to the prescribed drug regimen is crucial for suppressing the disease. And remember, those that are observed by healthcare professionals are more likely to adhere to the regimen. Remember that 3 negative sputum cultures means that the patient is no longer infectious. They also need to make sure that they're managing their anxiety and fatigue and assess their nutrition. And remember, our patient outcome is that we want this patient to return to their pre-tuberculosis health status. And that's the majority of what we need to know about TB. Just remember that the direct observation therapy is where the healthcare professional watches the patient swallow the drugs and may be indicated in some situations, but it also leads to better treatment success, fewer relapses, and less drug resistance. And make sure that we realize that everybody with a positive PPD does not necessarily have active disease, and that you understand the difference between the latent disease and active disease. And that's it. And I will see you guys about COPD. Yay!